Okay, so today I'm going to be speaking about bone grafts and the different types of both autologous bone graft, allogenic bone grafts, and also other bone graft substitutes. So just an outline of the talk, I was just briefly mentioning the indications for bone grafting techniques. As I mentioned, autograft, allograft, bone graft substitutes, growth factors, and some of the other techniques just briefly about the use of bone graft. Just to mention at the start, so what are the ideal sort of factors with the bone graft that improve its incorporation? So a bone graft ideally, and these are properties that obviously not all bone grafts have, should be osteogenic in producing new bone, both bone cells as well as mineral, and having a matrix which it comes with. It should be biocompatible, as in it does not produce an immunological response, and it's not associated with any rejection from the host. It needs to be bioabsorbable, as in it needs to be able to be incorporated into the bone and remodeled over time so that the body can adjust it to stress forces. It needs to provide structural support, so in depending on the situation which is used, for example in non-union fractures, it needs to be able to provide that strutting of the bone defect to enable potentially weight bearing through that bone. It needs to be easy to use surgically, so it's not too fiddly, and we can use more minimally invasive techniques. And also obviously needs to be cost effective, because across the broad range of indications that we have, we need to be able to justify its use without going to extreme expense. So just briefly on indications of bone graft, well obviously in the trauma setting with fractures, there's controversy around its use in acute fractures, where we more see it in our practice used in delayed or non-union cases. However, in acute cases it can be used for bone-filling defects, where there's a lot of comminution to fracture sites and can form a moulded bone graft. In cases of osteotomies, it can also be used as solid bone blocks. I'll speak about the different types used in that circumstance. For example, opening wedge osteotomies for correction of deformities, where a bone block can be used with a strutting plate. Also in tumour surgery, so when benign or malignant bone tumours are removed and we need to provide some sort of structural support to get remodelling of that bone. In cases of arthrodesis, so where we're taking out articular surface and potentially shortening the affected limb, blocks of bone can be used. And in terms of cases of infection, well, that's more about resection of tissue and filling up bone voids. And just on the right there, a case of non-union, with hypertrophic non-union, you can still see the fracture evident, and this case may well go on to needing some of that bone resection and the segment of bone graft incorporated. Okay, I'll just go over the different types of bone integration and the properties of bone graft. So, firstly to mention osteoconduction. So, osteoconduction is the property of a bone matrix. So, it's a scaffold for which it supports the formation of new bone. And so, it's really the, if you imagine cancellous bone, that fine architecture which provides the ingrowth, provides this, the scaffold for the mineralization and for the osteocytes to form on it. Osteoinduction. So these are the factors that support the mitogenesis of undifferentiated mesenchymal stem cells. So when in a situation where there's a bone defect, there will be migration of mesenchymal stem cells into that region, and it's the process of inducing those stem cells to then form osteoprogenitor cells that go on to form osteoblasts, osteocytes, and the deposition of new bone. And those mesenchymal stem cells can actually come from different sources, and mostly the bone marrow, we imagine, but also the periosteum, the cartilage, and even the muscle, and also the vasculature can provide stem cells. And finally, osteogenesis. It's the process of bone deposition, and that's osteoid. So it's when the osteoprogenitor cells are formed into the osteoblasts, and they're depositing the new bone formation on that scaffold. So this is just a quick summary slide about autografts versus allografts and the different strength characteristics. And really, cortical graft is less used in the allograft setting. We more use cancellous graft in our practice. and cancellous grafts really has no structural strength because it's a crushed bone matrix. And the autograft, being fresh tissue and being from the same body, has a lot of inductive factors with it. So there's growth factors, bone morphogenic proteins, and all the factors which induce the stimulation of new bone. Just briefly mention the bone incorporation, so the phases of healing. And so just to remember that to actually unite a fracture or a bone defect, you need to have existing matrix for the mineral to deposit on. You need to have progenitor cells that can differentiate and then form this new bone. And you also need to have the growth factors that I mentioned, which is the osteoinduction effect. So in, for example, a fracture situation, you would have a hemorrhage, which brings in vascular supply of a cellular infiltrate, and that comes with some stem cells, but some of the stem cells are from the marrow, as mentioned. But also with this, you get all the growth factors, and you get angiogenesis and capillary ingrowth. Between the sort of day 0 and 1 week mark, you start to get some bone resorption with osteoclastic activity, removal of the necrotic bone, as well as apoptosis of some of the still living cells at the fracture site. And this is also the phase of the soft callus formation, or the immature woven bone. The middle phase is about deposition of osteoid by the osteoblasts and the maintenance of that by osteocytes. And it's where seams of osteoid are deposited surrounding the core of necrotic bone, which is reabsorbed from the early phase. And this is really the formation of hard callus in this middle phase. And the late phases are about bone remodeling, which is in relation to the stress response with Wolff's law. And it's the transformation of the immature woven bone, and then to the hard callus, but then to the more normal situation, which is lamellar bone, healthy bone. Okay, moving on to more about bone grafts now. So autologous bone grafts are really the gold standard of bone graft use, and they can be from a variety of sources. And as obviously you know, bone can come in different forms, cortical and cancellous. So cortical forms are usually cortico-cancellous anyway. For example, fibular and rib grafts, where we're mostly getting a thick cortex. But cancellous forms, when we harvest from iliac crest sites, where a small window can be made in the iliac crest bone to harvest the medulla. The proximal tibia can also be used, and in other circumstances where local surgery is performed. For example, in scaphoid oros, for example, you can take a small bone of tricortical distal radial graft within the same incision as your scaphoid oros. I've also seen olecranon bone graft used for plugging distal radius bone grafts as well. Also to mention, and I'll speak about later on, is the bone marrow, and that's really just the harvest of the mesenchymal stem cells from the bone marrow, and also some of the growth factors, and I guess that's another form of autologous bone graft. I won't go into the discussion about vascularized versus non-vascularized bone graft, but there's always going to be controversy about whether bringing a blood supply with, for example, a tricortical bone graft is of more benefit than just implanting dead tissue. And the problems with autologous bone graft, well, it's fairly obvious that you're taking tissue from the host body, and therefore from a site which is uninjured otherwise. And so there's going to be obviously the cosmetic aspect of making a separate incision if made, for example, iliac crest, the formation of a hematoma at that site because you're taking away tissue, the potential for other injury to other structures, in particular nerves, and that can be, for example, iliac crest bone graft, the lateral femoral cutaneous nerve, or the peroneal nerve, and other structures like causing a hernia. The potential for fracture, because certainly harvesting bone graft is not without a bit of force which is used, so there's a potential for causing a higher energy fracture. Obviously pain from that site, and with any wound, the risk of infection. And really, the other factor is the fact that there's a real limited quantity of bone that you can harvest from autologous tissue, because we're not wanting to increase the chances of all these factors, and therefore we can't take too much bone. So moving on now to bone allograft, and I spoke actually during the week to the BIFM, one of the coordinators there, who's from the Living Bone Banking Program, and she spoke to me about the history of it. So it was first set up in 1996 in Victoria, and it is currently a system which harvests bone both from two sources, from living tissue and the other is from the cadaveric tissue, so that's obviously not the living bone. The living tissue is interesting that it's solely from femoral head tissue that's harvested, and that's from total hip replacement surgery. And since 1906, on average, is about 800 femoral heads per year are harvested from different procedures around Victoria, and it's both in the public and the private sectors. It involves a research nurse, and here Shelley coordinates our program, and that's been since 2011, so we're a bit of a late adapter to the system. And she said that Western Health, on average, about sort of 8 per year are harvested. So the femoral heads, the living bone actually makes up the majority of the bone graft that they have in store in the allograft, and less bone actually comes from the cadaveric donors. And cadaveric obviously requires a consent process with the family, and it's obviously the victims of, or the autopsy specimens that they have through the VIFM. And if it's cadaveric tissue, it's they harvest both humeri, both femurs, tibias, and also some of the iliac crest as well. With the cadaveric tissue as well, as it's a less quantity. It's interesting to think about the amount that it costs to actually use the allograft tissue. So it comes in these different forms. It is actually a picture from the Musculoskeletal Transplant Foundation in America, which is this is a government program, but it's actually the dispensing of the bone graft is coordinated through Synthes, and they have it in different forms with I'll speak about later demineralized bone matrix as well. But here it's directly from the government program, the VIFM, and she said that for 50 cc's or 50 mils, it costs $2,596, and that's the Medicare rebate. So basically, the hospital is not charged for that. It's so if we use bone graft here, for example, 50 cc's, then the VIFM is paid by Medicare directly, $2,500 for the expense of going through the harvesting process. And she said actually that's usually working on a bit of a loss as well. It actually costs them more to process it, and they don't get enough money to usually float the system. But anyway, it's still performed. And so the VIFM uses tissue which is fresh frozen. So it's freeze-dried. So this tissue, I've looked at American data, and freeze-dried tissue can be -20 or -70 degrees, but here we actually do it at -80 degrees. When it's stored at -20, the shelf life's only 1 year, but at -70 or -80, it's usually up to 5 years, and we keep bone here for 5 years. When it's actually initially harvested, it's kept in quarantine for the first 6 months, whilst all of the disease transmission paperwork is done, and that actually involves both the consent process as well as testing the sample at 0 and 6 months to make sure that it is definitely clear of all these factors. All the bone undergoes gamma irradiation, and then freezing at this -80 degrees, and then it can be used, as I said, for up to 5 years afterwards. We don't actually process any demineralized bone matrix in Victoria, and I'm not actually sure about interstate whether it's processed at all, but my understanding is that DBM is less used in Australia anyway. These are all the viruses and the factors which are tested, including syphilis. However, apparently, obviously, prions can't be tested, so that's something which remains a risk factor. Just a picture of, this is just a random picture of the internet, but that's usually the form that comes in, a little glass vial, and when rehydrating the bone graft, one way which is used is just using autologous blood, but also bone marrow can actually be used to rehydrate the material. It comes in different forms, particulate or structural, and we really only have particulate forms here with granules. And this is just a picture from Synthes website showing the different forms that they offer through the Musculoskeletal Transplant Foundation, in both chips, larger chips, and larger blocks. So larger blocks are obviously better for a bit more structural stability. But again, these are really cancellous bone grafts. They're not providing a great amount of structural stability anyway. Now, I said irradiated allograft is what's processed here in Victoria. There's also discussion about fresh frozen allograft and whether it's a greater benefit in terms of incorporation and also those osteoinductive factors, which are really frozen and therefore mostly destroyed in the processing. There's actually a group in Queensland who put out a paper in this journal in 2009 who compared the two, and they found that actually the sterility of the irradiated allograft actual product is better. so that it doesn't. Gamma radiation does reduce end product sterility, and therefore improves the shelf life of the material, and therefore decreases the amount of wastage. However, it doesn't actually follow through to reducing the chances of clinical infection, so it's not actually observed to do that. And there's very limited evidence at this stage that fresh frozen is any better than irradiated allograft. However, if you look very closely at the studies, there is a suggestion that there's a trend towards greater incorporation of fresh frozen non-irradiated tissue compared to irradiated. So demineralized bone matrix. So this is a form of bone allograft, which is treated with acid extraction, which removes the mineral content and leaves the collagenous structure of the bone behind, as well as some of the non-collagenous proteins. And this includes some of these bone morphogenic proteins and growth factors, but really in very trace amounts. And the DBM is usually formed into, I'll speak about it later, but we call bone composite materials when it's combined with other synthetically produced BMPs, for example, recombinant BMP, and then it can be used as a graft. So this is DBX, which is a Synthes product, and it's not actually available in Australia. I'm not sure if Grafting is. Grafting is from a company called Horizon Medical, I think, and it's in the form of a sort of putty. So DBM, being able to provide that bone matrix, therefore provides a scaffold for bone formation, and also has that osteoinductive effect with some of these growth factors. And the way that it's actually produced in these composite materials, it can be combined with a collagen base. So that's what DBX is. It's a DBM with a collagen base as a collagen carrier, but also can be combined with hyaluronic acid and glycerol, which I'll speak about later. So now I'll speak about bone graft substitutes. They've got different names, orthobiologics or biomaterials, and different names used by some of the major companies. Firstly, about calcium phosphates, then about BMPs, and some of the composite grafts which can be formed between these two, and also about polymethyl methacrylate. This is a slide from an article in JBJS from 2007, which describes the different calcium phosphate products. And so here we can see the cements, and then the ceramic or sort of more dry bone graft options, and then some of the composite options. And I'm not sure if many of these are available in Australia. I know the Chronos is available. Some of these other ones, Norian, for example, which is actually a fairly widely studied form of cement, is actually not available in Australia, as far as I'm aware. And some of the other ones aren't either. So bone graft substitutes, also just over here, there's different forms. So calcium phosphate cements, the beta-tricalcium phosphate, as well as the coral derivative hydroxyapatites, and synthetically produced hydroxyapatite. So bone graft substitutes, they are also conductive, as in they provide a scaffold for the bone formation and a matrix for the cells. They only have osteoinductive properties if an extra factor is added, for example, some of these growth factors or bone morphogenic protein, and sodium hyaluronate can be added. And this picture here is of a putty form where blood has been added, autologous blood, to rehydrate the sample. The evidence is actually quite poor. This is the study that's run on the Synthes website from 1985, they're justifying its use, where it's shown to be of benefit. And most of the studies of hyaluronic acid suggest that its benefit is really more in foot ulcers, and it's a chemical which can be used in neuropathic problems with diabetes, and that it can improve. That they say that it can improve. And also rat studies where it's shown to improve the incorporation of bone in rat femur samples. It's hyaluronate is actually a polysaccharide which apparently can cause increased cell migration, proliferation, adhesion, and angiogenesis. However, its use in bone is actually very limited in terms of literature. Ceramic, so in terms of ceramic grafts, the beta tricalcium phosphate is probably one of the more widely used forms, and that's Chronos is a form of that. And these are some pictures of some Chronos graft here from Synthes. It's created by a process called sintering, and it's where non-metallic mineral salts are heated to temperatures above 1,000 degrees, and they form highly crystalline structures. And so here's a picture of Chronos graft, for example. There's controversy about the different types of beta TCP in terms of the pore size. So there's micro and macro pores. So micro pores we consider very small ones, and these larger ones are macro pore. And the pore size, whether that's a determinant of incorporation or whether it's actually the interconnecting factor between pores. And it's thought that the interconnecting factor, so where these little holes are, actually improves the oxygen tension within the tissue, the graft, and therefore prevents blind alleys from forming in the beta TCP, therefore improving fine incorporation. Hydroxyapatite is actually much less used because it's considered to be a more brittle substance and it has got a very slow in vivo resorption rate. But it's thought that HA may actually have a slightly greater osteoinductive effect, and it's synthetic HA. So I might just mention here as well, a lot of the literature from both the article that was mentioned from JBJS as well as the Synthes website, so actually very old, 1992, 98, 1987. In particular, this study in 1992 was where a disc of TCP was implanted in total knee replacement surgery, and then followed up with plain X-rays, and they found that at 6 months the beta TCP discs had all become, you could not see them radiologically. So whether they're sort of incorporated or not is up for debate. The other one here from 1987 is where 40 patients with tibial plateau fractures and large bone defects were randomly allocated to autologous bone graft and hydroxyapatite, and there was no difference between autologous graft and HA at an average of 15 months of follow-up in terms of fracture unit. But again, only 40 patients were used. And just down the bottom there, that's that product here is Bone Save, which is a striker product, and it's a combination of calcium phosphate and HA, and that's thought to have other benefits to it. So just back to mention some of the cement. So those were the block forms, and this is a cement form. So cements are dissolved forms of calcium phosphate, and so the way, as you probably know, with a cement is when a precipitation reaction occurs in vivo, so when you implant it, between the calcium phosphate crystals grow and the cement hardens. And it's thought that the benefits of this is that you can actually custom fill bone defects or bone voids, and therefore get better sort of conformity through that bone void. However, the major disadvantage is the risk of extrusion of cement from the site that you're implanting it at. And so this is a study from JBJS in 2003, where distal radiuses were treated with implantation of cement. And it's interesting, they had 323 patients which they randomly allocated to closed reduction, plus or minus KYs, and KYs were used with or intra-articular fractures that they thought needed stabilising, plus or minus the implantation with injectable bone cement, which is Norian calcium phosphate skeletal repair system cement. And as I said, this is not actually available in Australia, this cement, other cements are. They actually started off the first few cases doing percutaneous injection of the cement, but found that they were getting a high rate of extrusion, so by case 13 they started doing a mini open approach, and then took the KYs out at a minimum of 2 weeks. It's interesting that the cases were all patients above 45, and there were no major highly comminuted, highly intra-articular fractures. They were all either extra-articular or simple intra-articular. In terms of complications, I think that it certainly wasn't without. It is from 2003, so back when techniques was perhaps a bit less clear as today. There's a high, 70% of the patients with cement injected actually had extrusion into the soft tissues, but that did not always cause a clinical problem. Only in sort of 12 cases in the cemented group there were tendinopathies, and there were actually 8 cases of tendinopathies in the non-cemented groups. And in terms of tendon ruptures, well, that's with the approach, and there were 6 cases of extensive pulsus longus rupture compared to 2 in the non-cemented group. The rate of infection, interestingly, cement injection was associated with a lower rate of infection, and these are all from the KY groups. However, one of these 4 patients with the KYs actually had osteomyelitis from the cement, and all the cement actually had to be removed, and then they needed an X-fix and a wrist fusion. So that was a very poor outcome for that one patient. And so the major outcomes of this study, that the use of the bone cement improved grip strength as well as range of motion and their function at an early phase, and interestingly decreased the swelling, and whether that's related to partial to earlier union. But in fact, at the later stage, which was at the 1 year mark, there was no difference between the 2 groups. And this is just an advertisement from the Norian website for different indications. For example, in depressed tibial plateau fractures, where they can be elevated with ORF and then filled with this bone void of cement. And that's obviously a good technique with very minimal extrusion, apparently. So beyond cement use, back to the Chronos, the blocks of calcium phosphate. Chronos is advertised to be used with bone marrow as well, where you can aspirate some bone marrow and put it in this device that they have as a product, and then therefore infiltrate the graft with osteoinductive bone marrow. And they have actually noted that there is a improved incorporation of the Chronos bone graft. Here we can see just blood itself, and this is with bone marrow. And certainly with 12 mg, you can histologically see that the Chronos graft is better incorporated. Beyond that, so that's calcium phosphate. Polymethylmethacrylate, or what we commonly see as bone cement, can also be used as a sort of a bone graft substitute, but it's really a bone filling material which is not reabsorbed, and is really to fill a problem where you're not expecting bone resorption and remodeling over time. And it has been labelled for use in vertebroplasty in the past, but my understanding is this is not performed anymore in Australia. And one of the current products which is used is in augmenting a intramedullary nail for a fractured neck of femur, and where there's significant osteoporotic bone, where the nail can be implanted, and then cement can be injected up through the femoral head to improve fixation of the lag screw. And it's controversial as to whether this has a greater benefit to the patient. There is some studies showing that there's less rate of failure of the lag screw, the locking screw, but it still remains to be clinically validated. And this is just a slide. It doesn't come up very well, but again, just mentioning that all of these bone graft substitutes, they're really providing a matrix without a great amount of structural support. They're all acting as a matrix with osteoconductive effects, and really no osteoinductive effects unless another growth factor is added. So moving on now to BMPs, which is a broad area and something which has come from the literature in the past 10 years. Bone morphogenic proteins are from a family of a greater family of growth factors called the beta superfamily, transforming growth beta superfamily, and they're osteoinductive in promoting osteoprogenitor cells to form. The way that they work is by producing cytokines, phosphorylating these cytokines, and therefore forming osteoblasts. There are other growth factors, such as the ones mentioned here. However, with BMPs, the two forms that we're commonly using are recombinant BMP2 and recombinant BMP7. And this is BMP2 is the infused bone graft, which is commonly seen in Australia. And BMP7 is otherwise known as OP1 from Australia. I'll show you in a moment the indications that we currently have in Australia. which is in lumbar spine surgery as well as open tibial fractures. And I'll mention these other procedures. There was a couple of controversial studies in the Journal of Bone and Joint Surgery from America in the past 10 years, where the first one here is from 2002, where 450 patients were randomly allocated to intramedullary nail with or without recombinant BMP2, and that was at 2 different doses. There was a 0.75 milligrams dose and a 1.5 milligrams dose. And in terms of the nailing, they were randomly allocated to either reamed or unreamed nailing, and that's an important factor in this study. However, this is a graph of the whole cohort, and it's showing that the standard of care group, which is in black here, united at a slower rate compared with the groups which were treated with a bit of BMP in different doses. So you can see the blue dose, or the higher dose, the 1.5, had a greater rate of incorporation than the lower dose. And so that study then concluded that in intramedullary nailing, or at least intramedullary nailing, there is a greater rate of union with the use of BMP, and this actually supported a lot of BMP use in the early 2000s. The other outcomes of this study was that they found that there was less infections, faster wound healing, fewer hardware failures, and a reduced rate of secondary intervention in non-union cases. Just to mention, the recombinant BMP2 is used with a carrier, which is a collagen-based carrier. So it's the BMP with a collagen, and the collagen is derived from it's bovines, it's derived from cattle. The latest, this 2002 study was then reanalyzed with a subgroup, and of just the grade 3 open fractures, because this included all different grades of open fractures. And the subgroup of grade 3 open fractures, which were treated with different soft tissue techniques, found that, that with the high dose, the 1.5, there was decreased bone grafting procedures and other secondary interventions performed for non-union cases. So it then supports the use of BMP in grade 3 open tibial fractures. So the latest study is by some of the same authors, and it was a response in 2011 to some of these results. And their study was just using reamed nailing techniques, so not the combined unreamed and reamed techniques. And in this study, 277 patients were analysed. However, there were less grade 3 open fractures compared to the original study in 2002. And they found that with reamed nailing techniques, with or without the use of BMP2, there was a very similar rate of progress to union by 12 months or 52 weeks in this group. So therefore, this study did not support the use of BMP in reamed intramedullary nailing for open tibial fractures of all different grades. They did find that there was actually, interestingly, an increased rate of deep infection with the use of BMP. So 2 tables were, this is a table from the study back in 2002, just mentioning how many patients were actually allocated to the 2 groups of reamed versus unreamed. So standard of care, there are really quite a few reamed patients, and also with the BMP groups, and a larger number in the unreamed groups. And this table is the comparison from the latest study between the two groups, and the rates of union, where a higher rate of union was seen with BMP in the earlier study, whereas really a very similar rate in the latest study with the ream nailing. The other controversy with this product, which they haven't specifically said whether that product was infused or not in tibial fractures, is surrounding the actual Medtronic product infused, which has been used for dental implants, but also other orthopedic spine procedures. and it came under controversy back in the mid-2000s after it was found that a lot of the original proponents of Infuse, orthopedic consultants in America, had actually withheld information about the side effects of Infuse's use, and this is an FDA from the US government, which is warning people against these potential complications, in particular with cervical spine. It's used in cervical spine surgery and fusions, where they noticed there was a number of respiratory complications from the use of Infuse. And this is just a statement from that FDA's website, saying, just describing some of those risks, such as nerve injury, sterility, urinary problems, potentially increased cancer risk, and that there are a number of lawsuits against these original authors that they withheld information. So in Australia, the Therapeutic Goods Administration only approves Infuse's use for lumbar spine procedures in skeletally mature patients. And the other one, OP1, which is BNP7, is approved in Australia for the treatment of non-union of long bone fractures secondary to trauma. So that's the current Australian product. Yep, just a couple more slides. And just other bone graft substitutes. So as I mentioned before, bone marrow is really aspirating those growth factors for implantation, and that's really got very limited evidence in orthopedic practice because it's really not providing any structural support. Whether the use of other blood products such as platelet-rich plasma is of benefit, certainly in terms of rehydrating samples, allograft tissue, it can be of benefit, but it's not shown to have much use in wide practice. The use of other irrigators and reamers, such as the RIA device, where tissue is harvested from the medulla, but that's really only in problems of non-unions for cases of that same bone. You wouldn't really harvest it for use in other tissues. And in terms of other techniques of using bone grafts, impaction grafting for revision arthroplasty, for example, where morselized bone is used and impacted around a new prosthesis, and whether this actually incorporates well over time is controversial. As the study is suggesting, there's actually a large necrotic area, and also the supplementation of hardware, for example, in spinal surgery with bone graft implanted in cages, which provide some greater structural support and therefore improved load bearing, whilst the bone graft is being incorporated. So there's my references.